Honorable Chairperson, panelists, and ladies and gentlemen. Good evening and Assalamu alaikum. I welcome you all to this International Inter-Ministerial Conference on Evidence for Action, South-South Collaboration for ICPD Beyond 2014. I'll speak on right-based approach to reproductive health programming for adolescent and vulnerable group, evidence from Bangladesh and to some extent from South Asian region. At the beginning I say that reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. So bearing in mind the above definition, the reproductive rights embrace certain human rights that are already recognized in international laws, international human rights documents, and other consensus documents. So what are the rights? These rights rest on the recognition of the basic right of the couples, individual to decide freely and responsibly on the number, spacing, and timing of their children, and to have information and means to do so. To attain the highest standard of sexual reproductive health also includes the right to make decisions concerning reproduction free of discrimination, coercion, and violence. So what are the specific rights relevant to sexual reproductive health? Right to highest attainable standard of health, right to life and survival, right to liberty and security of person, right to be free from torture, cruel, inhuman, and degrading treatment, right to decide freely and responsibly the number and spacing, right of women to have control over and decide freely and responsibly on matters related to their sexuality, including sexual and reproductive health, the same right of men and women to marry only with their free and full consent, right to enjoy the benefits of scientific progress, right to privacy, participation, education, and information, right to freedom from discrimination, right to freedom from violence against women. So what are the components of right-based approach? If we look at the participation, increasing access to information on reproductive rights, ensuring poor and vulnerable people, supporting civil society and organizations to monitor, supporting women's group and other vulnerable groups, including people with HIV and AIDS. So you are to include the targeting poor, vulnerable, and excluded group, disaggregating data to monitor disparities, and to look at the outcome, the promoting equality for women and men, to empower women to control their sexual reproductive lives, working with men and boys, tackling discrimination in service provider. So the obligation comes, the reforming legislation and policies, implementing laws and policies, implementing anti-discrimination laws, building in-country capacity, guaranteeing a means of redress for violations. Building capacity to policymakers and service providers to respond to the voice, supporting governments to put in place the right-based monitoring tool, harnessing in-country capacity to monitoring action. The countries of the South and Southeast Asia encompass a highly richly layered mix of culture, religion, language, racial and ethnic groups, and economic and political system. Although South and Southeast Asia are very different setting with regard to many aspects of adolescent sexual and reproductive health, there are also important commonalities. The most young adolescents throughout the region have little, if any, accurate information about their bodies and their sexual and reproductive health. So if you look at the situation, in South Asia, 26% of all Bangladeshi girls aged 15 to 19 were married at the age of 14 or younger, compared to 14% in India, 9% in Nepal, and 7% in Pakistan. Arranged marriage of the girls before 15 do appear to be declining in these countries. In Bangladesh and India, 6% and 2% of all girls aged 15 to 19 years became mothers at the age of 14 or younger, most without the help of a skilled birth attendant. Maternal and newborn deaths and complications of these girls are common. So you look at the trends of the adolescent birth rate. If you look at the 2010, so still it is about more than 45, about 15. So if you go to the MDG in 2015, it will be 45, if you go in this way. In India, more than 1/4 of women in one sample had been sexually abused at the age of 9 and 12. Half are abused more than one person, and almost all abused repeatedly. Similar pattern of incest and sexual abuse are reported throughout the literature. Community-based right programs in India cover reproductive rights along with literacy training, economic development, and other activities to empower women in every aspect of their lives. They have encouraged women to reject early marriage and seek help without waiting for men's approval. Throughout South and South Asia, girls from poor families are susceptible to being recruited or sold into prostitution by their families, which places them at high risk of HIV and sexually transmitted disease. A sample of young adults aged 18 to 25 in Pakistan reported that the information they receive about puberty and sexual development when they were younger often led to confusion and stress. In Bangladesh, adolescents aged 12 and over enrolled in a non-governmental reproductive health program are eager for information about their bodies, relationships, sex, pregnancy, family planning, and STIs. In Bangladesh, India, and Indonesia, only 5% married girls aged 15 to 19 know without prompting that condoms prevent HIV, and only 9% in the Philippines. In contrast, 4% of the married girls from 15 to 19 years in Nepal and 65% married boys know this. So situation in Nepal is better than this region. Evidence shows that withholding information and services from young people only increases the likelihood that if and when sexual initiation occurs, it will be unprotected. So Bangladesh experience, if we look at in detail, the policies of UN agencies have helped advance the reproductive health agenda, including that for adolescents. And during the decade after the conference, ICPD 1994, the government has translated international treaties into different policies, strategies, programs. And there are a number of policies, strategies, programs that were developed and revised in different times. Now the National Health Policy 2011, it includes programs, operation plans for reducing maternal and child mortality, prevention of infection, provision of safe reproductive and sexual health service, clean delivery, and expanded family planning to enhancement of fertility status. National population policy was drafted. Bangladesh National Strategy for Maternal Health was developed in 2001, focusing emergency obstetric care, reducing maternal mortality. It is being updated now. National Policy for Women Advancement in 2011, which is targeting towards elimination of disparity among women. Menstruation regulation policy was adopted in 1979 to ensure access to legal and safe menstrual regulation service. Tribal ethnic health population nutrition plan for health, population and nutrition sector program that has been developed for all actions from 2011 to 2016. And Bangladesh also has laws and acts like Bangladesh Labor Act, Domestic Violence Act, Prevention of Cruelty to Women and Children Act, Acid Crime Control Act, Child Marriage Restraint Act, Dowry Prohibition Act, Right to Information Act, Regression of Violence Against Women and Children Act. And Bangladesh also ratified various declarations, conventions, and treaties like Human Rights Convention, right to health, right to social and political rights, economic rights, ICPD 99 in Cairo, Beijing Platform of Action, and other declaration and acts. And Prime Minister of Bangladesh is committed in the UN Summit 2010, specifying the doubling the birth rate by traditional attendants, reducing the adolescent pregnancy by social and political mobilization, enacting legislation to end child marriage, provision of safe reproductive health care, and halving the unmet need for pregnancy. So there are a lot of programs and intervention and actions in Bangladesh, like Health and Population Nutrition Sector Program, which is the most important sector in the country, and they have the specific strategies streamlining the access and quality of maternal, neonatal, and child health services, particularly supervising deliveries, achieving the Millennium Development Goal and Millennium Development Goal 5. And a lot of operational plans are being carried out under Director General of Health Service and Director General of Family Service. And for child and adolescent health, 13.61% of the total budget of the program has been allocated. And there are programs like promoting women's access to resources like National Nutrition Program for Women, Communication and Program for Reduction of Maternal Mortality and Violence Against Women, Women-Friendly Hospital, and Community Clinic. There are 12,000 community clinics. So major activity of the sector program includes doubling the percentage staffing, first aid, EMC, Ministry, Department, Managed Training, Social Safety Net. So you see the trends of skilled birth attendant. So the trends of skilled birth attendant is increasing. And if the target is, the way we are progressing, if we reach we cannot reach the 50% target. But there are gaps between the treaties and convention and the actual picture. In Bangladesh, maternal mortality is still high. Currently, maternal mortality ratio in Bangladesh 194 per 1 lakh. The target, if we have to face, we have to we have to reach 143. Pregnancy-related death is 2001 per live birth. In ICPD one data, highest quantile people has got mortality ratio is 208 per lakh, as the lowest quantile is a 220 per lakh pregnancies. Inequalities and discrimination towards women in terms of sex, race, religion, economic status have a grave impact. Liberty and security of women in Bangladesh is not satisfactory. 2/3 of the women reported they can go alone to health center, while 16% go without accompanied by children. 18% women cannot go to health care. Situation is like that half of the ever married women reported having experienced physical violence by their husband. Women with no education have averaged 3 children compared to 2.3 among women who have completed secondary school. The situation of access to service is improving in Bangladesh. There is urban-rural differentiation in antenatal care. Receiving postnatal checkup also there is difference. According to BDS data, 32% of Bangladesh attended medical training person. Antenatal care is urban-rural delivery difference. Age of marriage is also increasing. Unsafe abortion is a related death to the mother is gradually decreasing due to good practices, best practices. So through the interventions in Bangladesh, or through the best practices, 5 prioritized technical intervention area, there is reduction of maternal neonatal mortality to reach the MDG goal, and we can progress toward the sustainable development goal. So in conclusion, I say, effective addressing reproductive health problems for an integrated right-based approach that draws on the fields of health, ethics, law, and human rights. Awareness raising is required among the public health providers and non-government organizations for the need of a special clinics or program for adolescent and vulnerable population. Effective integration of service for sexual and reproductive health is required, resulting in improved maternal liver health, accessible, highly quality family planning, contraceptive choice, elimination of unsafe abortion, reduced incidence of sexually transmitted infections, greater awareness of sexual health, and reduced risky behavior. So thank you all.